CataractCoach.com, podcast series, episode number 31 with Dr. Jane Edmond. Dr. Edmond is chair and professor of ophthalmology at the University of Texas, Austin, Dell School of Medicine, and also the director of the Wong Eye Institute. Now, this is a new med school and a brand new department, and she explains her passion and her focus and her ideas of developing this. They just started a residency program. Again, it's a new department and a new eye institute. How do you build a faculty? How do you develop patient outreach, clinical care? How do you work with the community ophthalmologists to make a bigger and more cohesive department? How do you integrate patient care and education and now also research? It's a really complicated process, and she gives us a lot of great insight as to what she's doing to build such an amazing program. She's also the incoming president for the American Academy of Ophthalmology, and she gives us some insight as to what she has planned for that presidency. It's a fantastic podcast. I know you'll enjoy it, and you will love her passion. Check it out. Welcome back to our Cataract Coach podcast today with Dr. Jane Edmond. Dr. Edmond has been faculty at many universities, Wong Eye Institute, Wills Eye Hospital, most recently Baylor, and now she has an amazing position as chair and head of the new Wong Eye Institute at the Dell Medical School. So what I want to delve into is all the things that it takes to start an eye institute and a whole department from scratch. So Jane, welcome and thank you for doing this.
Thank you, Uday. I'm very honored and pleased to be here. Love the invitation and very happy to be here.
Take us briefly through your path. So you have a very, very ultra-specialized field. You're not only an ophthalmologist, but a pediatric ophthalmologist and a pediatric neuro-ophthalmologist. Tell us about that.
So, Uday, when I was as a resident at Baylor, which I had two happiest days in my professional life, and that was getting accepted to Baylor for medical school and getting accepted to Baylor for my residency. And as a medical student, I just thought that the coolest kids, the coolest residents were ophthalmology residents. So I think we all share that our path into ophthalmology, that ophthalmology is a perfect blend of surgery and being in the clinic. Our colleagues are super smart and very diverse group. But to my path into pediatric ophthalmology, that's where I started. That was my first fellowship in 1990 at the University of Iowa. And that was inspired by Gunther von Norden. So everybody knows Dr. von Norden's name. It's the seminal textbook in the pathophysiology of amblyopia and strabismus and the management of strabismus. And we would have grand rounds every week with live patients back then. And the resident on the service for pediatric ophthalmology had to present. And Gunther was the smartest guy in the room. And I just wanted, head tilt, hypertropia with a head tilt to the left and hyper that's worse on opposite gaze. I mean, everyone was always in awe of Dr. von Norden, and I just wanted to be a tiny bit like him. And his partner was Paul Steinkuller, who is probably the kindest, most wonderful human being on the planet. And if I could just be a little bit like him. So they were my inspirations to proceed to apply for a pediatric ophthalmology fellowship. But the neuro fellowship was done 15 years later. And I did that when I returned from my appointment at Children's Hospital of Philadelphia / Shea. And I had a day a week at Wills. When I returned to Houston after those 7 years, came back to Texas Children's and Baylor, and the hospital, Texas Children's, had grown immeasurably.
Sure.
The pediatric neurosurgery service had exploded, patient population in that space with pedi neurology, all the neurosciences there had really grown. And it was pretty apparent that we did not know how to manage these patients. And I had a child in my first stint at Baylor, or at Texas Children's, before I went to Philadelphia. I had a child go blind from idiopathic intracranial hypertension. It was called pseudotumor cerebri back then. but it was mismanaged on the neurology side. I didn't take ownership of the patient, and it was a very tragic situation. But coming back, I could foresee this happening again because none of us were neuro trained, and we really didn't. I didn't understand how to look at an optic nerve until I did that fellowship. And I did that fellowship. I stayed at home at Baylor, and I did my fellowship with Rod Feruzin, who was my resident at Wills. So
wow, small world.
The teacher became the student, and I was also Uday burned out. I had really enjoyed my time at Children's Hospital of Philadelphia working in interdisciplinary teams. I was the point person for pediatric ophthalmology on the craniofacial team, and I just felt that was really a development, a growth time for me. I brought that education to pediatric ophthalmologist through national meetings, and I missed that sort of super subspecialized care of patients. So, and kind of burned out of your typical accommodative ET and amblyopia. I mean, we were serving that well, and then the need of the hospital compelled me to do this year fellowship. So for 4 days a week, I was in clinic I was Rod's fellow, dilating patients, taking histories, getting intraocular pressure. But it was the best Renaissance factory reset for me. So I went back to Texas Children's after that year and became a pediatric neuro-ophthalmologist. And at that time, there were only about 20 people in the U.S. that were self-identifying as pediatric neuro-ophthalmology. And it was a great service to the hospital, wonderful service to me in my career. I don't really think my career, it was not flatline at that point. It was like on a real slow trajectory until I did that fellowship, and then things started to take off.
Wow. Yeah. For those who don't know, where you were there in Houston, that's the world's biggest medical center, period.
Yeah, Texas Medical Center. It is giant. UT Houston is there. Memorial Hermann is their hospital. Our county hospital that Baylor served was Ben Taub, Baylor College of Medicine, MD Anderson, the Methodist Hospital. So yeah, it rocks.
Yeah, so obviously with a place that huge, I'm sure there was a lot of work for a pediatric neuro-ophthalmologist. It kept you very busy.
Well, in Houston, I think at this point is the third largest city in the U.S., maybe the fourth back then, maybe vying for 3 and 4. Last time I checked, it was 6.5 million. So, yeah, large place with lots of patients.
Yeah, and you stayed on as Baylor faculty for quite a number of years as well.
I was just in Houston last week. Andy Lee is chair at the Methodist Hospital, Weill Cornell, Department of Ophthalmology, and he is president of the Houston Ophthalmological Society, and he was my resident, and I was invited back to accept the Lifetime Achievement Award from Houston Ophthalmological Society Methodist Hospital. And I was just so grateful because I was going back to my professional home. So Houston, sure. Baylor, Texas Children's, I really, all of my accomplishments, if I've had any, are due to having been trained there, mentored there, supported there. So it's a very special place for me.
So then that's a big change for you to leave such basically a home.
Correct.
Near and dear to your heart to then move, over to Austin. Tell me about that.
So I knew about the search for a chair at this new medical school, Dell Medical School, UT Austin, but I didn't put my name in the hat because I knew of maybe 4 chairs of departments who are applying for the chair of this department. And I thought, I've never been a chair. I've never been a vice chair. I've never been a program director. I've had a lot of leadership roles in APOS and the academy, but never in a school of medicine or a department of ophthalmology. And there's no way I'll be considered. But about a week before the search, or the ability to apply for the chair, about a week before it closed, I was called by someone on the search committee and was asked to to apply and submit my CV. And I began to look more. That was very interesting. I thought that somebody like me could actually be a chair. I didn't have to be an current chair or have all those leadership roles to be considered. So I was very interested, and I began to look at the school and our Dean, Clay Johnston, our inaugural dean, and the vision he had set forth for the school, an inclusive ecosystem, which to me meant collaborating with community partners to build a medical school to care for a city and maybe and hopefully at one point beyond. And I'd been in institutions that there was a town and gown situation where there was the community docs, and then there was the academic side, and there was a big schism. But that's not how you heal and care for a community. So that was very inspiring to me. Plus many of his other visions and goals for the school. So I applied, and in the application process, I found out that there was a huge unmet need for the safety net population in ophthalmic services. I found out that there was one comprehensive ophthalmologist who had a hospital district contract to care for the entire population and all of the hospital district contract insured patients. He was the only one who could perform cataract surgery on these patients. There were retina docs on the contract, there was oculoplastics docs on the contract, but one comprehensive ophthalmologist to care for the entire population. And he had a backlog of 300 cataracts on his list to operate, and he was having a hard time finding an ambulatory surgical center to accept the hospital district payment for cataract surgery. And Uday, that was probably 50% of the reason I was so interested and compelled and motivated to take this job, because that can't happen in our capital, in my state. I have a big heart and commitment to the care of safety net population. Pediatric ophthalmologists, we care, our typical patient population is 50% underinsured and 50% commercial payers. That's typical for pediatric ophthalmology, and to see this happening in Austin, Texas was just completely unacceptable to me. So that is one of the very primary drivers for me to be compelled to take this job, or compelled to apply for the job. And in the end, I got the position and was the first employee in our department.
Oh, I think that's amazing. You bring what I like is you bring a very fresh perspective. I bet you that's what the committee liked as well.
Yes, and I was also told, Uday, there was a face-to-face interview was provided to 20 applications were 20 CVs were accepted. 5 applications were allowed to come on site and meet with leaders, but not the dean. Then the list got narrowed down to 3, and then to 1. I was the last one, and I finally got to meet with the dean on the last day. But I was told in the interview process, which I think is important advice for our younger listeners when applying for a job, that the others that had come through, many of them applying for the chair position, had not researched who they were meeting with. Had not researched what was happening in Austin, had not done any investigation in how you actually start a residency, because all of us come from these legacy systems where we're part of the residency training program, but has anyone read the 300-page application that from the ACGME and all the elements that are necessary to start up and support a residency. I certainly had not until considering this position. So note to younger listeners, research who you're meeting with, who are they, and how can you fit into the culture and system of the hospital, and can you do this job? I wanted to know, can I accomplish what is expected of the chair, because I don't want a job that I'm not going to be successful in.
Right. Well, speaking of research, I did mine. So I know you're back at your hometown university. You did your bachelor's degree right there at UT Austin. Right, the hook 'em horns, right?
Hook 'em horns, exactly. Yeah, I'm the only chair here. Actually, the only person in a leadership position that is a UT graduate.
Wow. But the city of Austin, though, and the surrounding area has grown tremendously since you did college. I mean, it's crazy, the growth.
Yeah, it's all your brethren coming here, pal. It's Californians.
It's all the Californians.
Driving up home prices.
We're sick of paying 13% California state income tax.
Yeah, yeah. There's Texas has a better tax structure.
What's the overall population then of the greater Austin area? It's today.
So, yeah, right. So about a year ago, I checked into that. I think it's a little over 1.5 million. Austin metro area.
And then the surroundings going to be push it beyond 2, even to 3. So
yeah.
That's a huge population now. So now your safety net's even more strained.
Correct. And then that's absolutely right.
Well, I also think it's brilliant the way you're pairing with the community doctors. So I did my research as well. So I know you paired up with 2 big retina groups. You paired up with the ophthalmology consultants group, TOC, which is one of my former residents. Tanuj Nakra was one of my residents. He won my award for best. He won my award for best surgeon when he was a resident. But I love how you paired up with all these people.
Well, they had before I took the chair, the more academic inclined ophthalmologist in Austin had already become faculty, affiliate faculty, which is more community-based faculty with the Department of Surgery. So I inherited that list of 15.
Sure.
That just showed their academic intent. And as these practices add additional partners or physicians, they become faculty with us. And most recently, I have asked, and happily, Tanuj Nakra and Vic Duraraj and Rich Allen have accepted regular faculty appointments, so they're full-time faculty in my department because they're so committed to education of our residents. And they see patients, safety net patients, which is another requirement of mine for faculty positions, either affiliate or regular.
Well, that is fantastic. I mean, those patients are so fortunate. You get someone, who's that incredibly talented with such great training, and they care for the rich of Austin and the safety net at the same time. That's amazing.
That is correct.
Well, I think it's absolutely brilliant to pair with the community ophthalmologist, and a lot of programs did that in the past. Like UCLA, I was never full-time faculty at UCLA, but I was an affiliate faculty for 22 years. And so climbed up the ranks, and I attended 10,000 resident cases, 500 a year for 22 years. But
wow.
But sometimes the programs end up changing. I thought it was a great move at the time, but it used to be how the university would work in collaboration with the community, which is exactly what you're doing, which I applaud you for. But, admin stuff happens, bureaucracy. So actually, very recently, this year, UCLA has now cut ties with all community ophthalmologists. And so, it's a big, bold move. Even rescinded titles. Like you can't use the word UCLA in your titles, your biographies. Okay, right. As you wish.
I recently interviewed for a position within my department. One of your graduates, from recent graduates from UCLA ophthalmology, and this individual spoke so highly of the faculty like yourself that are in the community, how rich that experience was.
Sure.
Maybe a little bit more rich than having been on the main campus. The experience obtained and gained by individuals like yourself who, it's pretty selfless, Uday, what you've done and what the community faculty are doing at zero compensation. So they have a special place in my heart and in the department, and I applaud and celebrate their involvement with our department and resident education.
I think the way you're doing it is absolutely brilliant, and it allows you to grow at a more rapid pace, and also basically just to help more patients.
Correct.
It's a win for everyone.
So I couldn't hire one of everything, right? And the department actually was begun out of a $20 million gift from a family of ophthalmologists in town. Dr. Mitchell Wong and his son, Dr. Shannon Wong, they practiced together. Shannon is obviously still in practice and does a lot of amazing videos like you do. Mitchell's now retired, but I hold them near and dear to my heart. That gift sort of forced our inaugural dean, who's very population health minded. Population health is a department here, not a division of internal medicine like in the vast majority of other schools. Ophthalmology certainly wasn't on his radar to establish as one of the 13 departments, but the $20 million gift from Mitchell and Shannon and their wives, Betty and Rose Wong, compelled him to establish this department. And in talking to the Wongs about why they gave $20 million to establish a Department of Ophthalmology at Dell Medical School, UT Austin, it's very moving to hear their story. And they use a quote from the Bible that's in multiple places in the Bible. I'm paraphrasing now, but those who've been given the most should be expected to give the most back.
Sure.
And Mitchell, his parents were grocers. They had 2 grocery stores on the east side of town, which is where all the poor people lived. This I-35 was a dividing line. Actually, until like 1955 or something, people of color or non-whites couldn't purchase homes on the west side of I-35. I mean, it's horrible. Anyhow, that's where Mitchell came from, and he became very interested in real estate, and this gift came out of the sale of property on the east side of town that is about a mile from the new Tesla plant. And
wow, amazing.
Mitchell's visionary real estate purchases were able to endow this gift. So I love that quote, and I love that very motivational, inspiring reason for giving back.
Oh, it's fantastic! Yeah, I know Mitchell and Shannon very well. Both amazing people. I've done Shannon's podcast. I was just gonna think, Shannon is an amazing surgeon. That 300 case backlog that the other guy had, I bet you Shannon could knock that out in a week.
Well, when I get the guts up to get my cataracts out, I'm headed over to Shannon's.
Yeah, actually, I visited him at his new facility, which is absolutely beautiful. And what I like the most about it, not just the gorgeous architecture, but boy, the teamwork there is so efficient to get cases done. But yeah, he literally could do all those, a 300 case backlog, I promise he could do it in a week.
So we want, and the education that for my residents from Shannon's Business Savvy, they're going to be doing in their later, PGY3 and 4, learning from Shannon, the business of ophthalmology. So
Brilliant. In fact, that's such an important part. So when I was teaching residents, I would do basically every month and every 6 weeks, I'd do a resident business dinner. I'd have a company arrange to take us all to dinner, a beautiful restaurant, and they'll present their product so they can cover our dinner costs. And then I'd have a topic. Let's talk about this time. Let's talk about marketing. Let's talk about surgery center ownership. What are the metrics you should be looking at? Let's talk about buy-in. How do you evaluate a practice? All the things that you're never taught in residency, I would have a resident business dinner every month, and I'd teach all the residents this.
Well, did you record those? Because those would be awesome for our younger listeners.
You live and learn. Didn't record them, but I mean, maybe I could start a next series on CataractCoach about the business things that you've learned the hard way. Because I've learned the School of Hard Knocks.
Yeah, and maybe you could consider inviting somebody like Shannon, others that have been in your same space that have been super successful in the business side of ophthalmology, starting practices, building practices, maintaining. I mean, trying to find a tech now, oh my God, it's a buyer's market. They hop from job to job and get better pay because there's such a, the workforce shortage in the ophthalmic tech space. We're certainly suffering it in Austin. I don't know of other communities, but staff retention, very important.
Yeah, absolutely. Because if you look at any practice, your number one cost is payroll.
Yep.
And so you got to keep the staff happy for sure.
So I practice Uday. I have a 30% clinical commitment, so one day a week in clinic over at Dell Children's Hospital, and a half day in the operating room. And I developed the department and clinic here at UT Health Austin, where my faculty practice. So I'll see the resumes of the technicians that we're hiring, and I don't see Shannon's practice anywhere on there because they stay there.
Yes, for sure.
Right. So there's a lesson learned from Shannon's ability to retain his staff.
Yeah, for sure. Well, I'll have to have him start the resident business dinner program there in Austin, and then I'll come be his faculty. That'd be great. No, so fantastic situation there. So tell me about the residency program. You're starting small, right? You just have started very recently.
Yes. So, Uday, getting a residency started. To do that, my first faculty member was Dr. John Shore, the legendary Dr. John Shore. He was one of the founding members of TOC, now retired, and Vic Duraraj is the managing practice physician now. But John was was retired and was interested in helping me with the application and starting the residency. And he'd had some experience because he had been program director at Harvard in the 90s. And he's given every major keynote speech in oculoplastic and was president of OMIC or in charge of OMIC, chairman of OMIC. Also had been president of ASOPRIS. So John worked on this for about 2.5 years, fleshing out the application, lots of open text boxes like how are you going to ensure that the residents are mindful of health equity, how will you ensure wellness, a lot of things that we never thought about when we went through training. We went through training, but he also had we had multiple sites like TOC for oculoplastics, Dell Children's Eye Clinic, which is part of Ascension, for the pediatric ophthalmology experience, the two retina practice, Austin Retina Associates and Retina Consultants of Austin. So John had this amazing relationship, 20-year relationship with these practices, incredible gravitas in our community, and he pulled these practices together and fleshed out the 52-page application following all the guidelines. We had to submit the application and get it and have the application accepted, Uday, by April 2021. It had to be accepted at that review committee. The ACGME Ophthalmology Review Committee meets twice a year, January and April. And if it was not, our application had not been accepted April 2021, we would have lost the opportunity to get Medicare dollars to support our residency. There's a 5-year window where a medical school aligns and affiliates with a sponsoring academic health system. Ours is a hospital, Seton, Maine, which is part of the Ascension system, which had never had graduate medical education assigned to it. 5-year window. And this was established in the 50s or 60s by the government, by CMS. So if we had not been approved after that April meeting, we would have lost out on the opportunity to have our residents, each resident funded at roughly $65,000 per year per resident by CMS forever.
Forever, wow, yeah.
And John and I looking through the volume of the safety net population and the minimum requirements for cataract surgery, which is the leading procedure. It's only 85 cataracts that are the minimum requirement, which I feel is not competitive. I wanted our residents to have over 200 by the time they graduate. 250, 225 would be ideal. So as John and I looked at the population, the safety net population, the population of Austin, we felt that 3 residents we could accommodate and fulfill that goal of that volume of the leading surgical procedure if we had 3 residents. 2 is too few. We talked to many programs that somebody goes out on maternity leave or becomes sick or FML.
Right.
That leaves 1 resident solo in that year, which is not ideal. So that's we came up with 3, and I talked to like George Williams and several other chairs of the smaller programs, and 3 seemed ideal. So that's what we went with, and that was what was approved. And we got the approval, obviously, from the review committee, from the ACGME for ophthalmology, and we had no citations, Uday, which is
unusual, yeah.
Like unheard of, actually.
Right.
Almost every application has citations that have to be corrected within 2 weeks or addressed. We had none, so it was pretty cool. I thank John Shore for all his efforts.
So 3 residents a year for the 4-year program. So your most senior residents now are PGY 3 or 2?
2.
2.
They just started. Because I got the funding, Uday, from CMS, I was able to add 3 spots to the transition year program, which is super competitive. I think it's about 16 years old. Formerly, these residencies that moved over to Dell Med had been affiliated with UT Galveston, then UT Southwest, then they moved to Dell Medical School. But the transition year program is about 16 years old, super competitive, like 700 applicants for 6 spots every year. So I was able to, because of the CMS funding, add 3 spots. So it's a guarantee. And, the ACGME is requiring that we provide the first year of training in our own institutions, in a affiliated institution. So that edict was just coming down when John and I were developing the residency. So we were lucky in that way.
Yeah, it used to be 1-year internship, which could be done anywhere else, and then 2, 3, 4 ophthalmology. But now it's all integrated 1, 2, 3, 4.
Correct. And I think it makes it much easier for residents to not have to scramble with ERAS and try to get a internship that may be in another state. They have families, they have spouses that work, kids in school. So it
makes it a lot easier.
Yes. And then there's 3 months of ophthalmology now. That was also part of the mandate, right?
Yeah, so your internship year is 9 months internship, 3 months ophthalmology.
Correct.
So you also have room to grow. So should you be able to provide more surgical volume, I'm sure you could even grow your residency more.
Correct, exactly.
Because one of the big things for me is I don't know if we're training enough ophthalmologists with 460-something residency spots for the U.S. a year.
We are not, Uday. So as a chair here, and because of the Wong gift, I was given the Wong Family Distinguished University Chair from UT. And it was due to their magnanimous transformational gift. One chunk of it went into my chair endowed chair position, which allowed me to serve in that role or have that title, but it also provided me the opportunity to give an investiture lecture, which is what endowed chairs from UT are offered. So this lecture was how to start a residency and department from scratch. So I did research, Uday, on the needs. Do we need another department of ophthalmology? Do we need residents? And absolutely we do. So there, I think it was a AAMC a few years ago, put out a paper about the prediction of the physician workforce shortage in 2032. Okay. We will be short between six, and I may not have the numbers exact, but in 2032 we will be short between 65,000 and 120,000 physicians.
Wow.
And then I drill down into ophthalmology. And while the metropolitan areas in Texas are predicted to be well served, obviously we like to live in major metropolitan areas, especially as subspecialists, but it's the rural communities, suburban and rural communities that are suffering. So yes, we absolutely need more ophthalmologists to care for patients. And there's the graying of America. So I also went back and looked at our population growth. So our population is not growing for more babies. It's growing because we live to 80.
Yeah.
Hopes to God. It's the graying. And then the healthcare dollar, whoa. We are 60 to 80, 60 to 70. So much of the healthcare dollar is used up in that demographic. And think about our eyes, like our retinas are falling apart.
Yeah, you look at the volume of cataracts surgery done in the U.S. So 20 years ago it was about 2 million cataracts a year. Last year was more than 4 million.
Right. So just another testament to how America is graying and getting older, and also we're staying healthier. So we want to keep our eyes. We want to see better. Like I do adult strabismus surgery, and the volume of adult patients that come to me with age-related esotropia has exploded. And I think in the past they just, I see some double vision at night, at distance, some crossing, and I'm just going to go into prisms or squint. They're not tolerating that anymore. They want higher quality of living. Right. They want their eyes to be right. They don't want to wear prism glasses. Right. I'm sure you're seeing it like monovision or the premium lenses. I don't want to wear glasses at all. So, yeah.
Right. They may be 80 years old, but they're still playing pickleball this Saturday.
Exactly. Right. Not me, but I'm glad they are.
But no, I think you're right. So I think we are not training enough, and then there are a lot of ophthalmologists who are not working full time. And then the other catch too is I think we're retiring more ophthalmologists per year than we're minting. So certainly there's going to be a huge need as things get further down. As the years go on, we'll have more and more need, and there's only so much more efficient we can be. I mean, when I was with the residents, I remember starting at the county hospital, they would book for the day 3 or 4 cataracts, and I was like, well. Here's how I do it in private practice. We're going to change a few things. We're going to start doing some metrics. We're going to measure everything. Time in the room, time out done, block done, first incision, end of surgery, drapes off, patient out of the room. So I time everything. Say, okay, here's where we need to fix the issues. And so then we book 12 cataracts in a day. Wow. 10 at the minimum. And so whatever backlog they had, your backlog is done in a month.
Wow. So Uday, did you have, what's like the average time for a PGY2, maybe at the end of their PGY2, I'm not sure when residents begin cataract surgery, but certainly PGY3 and 4, did you have different times allotted for those training years?
Yeah, so the most important thing is we never tried to rush the actual surgical cut time.
Perfect.
But when you have data that shows the patient was in the room at, let's say, 8 o'clock, and your first incision was 8:30, why?
Why, exactly.
And so that's far more important. So we have a whole series of videos and studies, case studies on CataractCoach.com about efficiency, including when you're a resident and all the appropriate metrics. So I've got like really a dozen or 15 videos about the topic. But yeah, it's far more important. If you are doing your training, or even if you're a young ophthalmologist listening to the podcast and you're in your first 5 or 10 years of practice, you really need to not worry about the actual cut time. It's far
Agreed.
more important to worry about, like, what are you dilly-dallying for? When the drapes come off and it took you 16 minutes to leave the room, why?
Agreed. So that is education that has to go back to the surgical center. How do you become more efficient there?
And I decided to track all these metrics. And I tracked it by, okay, let's do today. Who's the anesthesiologist today? Who's the circulator? Who's the scrub? Who's the resident? Who's the attending? Mm-hmm. And I learned that from Costco, because I was at Costco and they had this big chart on the wall of their checkup people and who was the most efficient and who was the highest accuracy. I was like, If Costco can measure these metrics, we can certainly measure metrics.
Yeah, we need to take a lot of, Pepe Martinez is one of our faculty. He's at Austin Retina Associates. He has a product at the Academy website, or the Academy store, American Academy of Ophthalmology, obviously, on the lean model. So taking that, I think it's from Kawasaki, or I've forgotten the Japanese car maker that created the lean model. So lean ideas and business practices can make us better and more efficient. That's what we need to do.
Right, and you can help more patients. Speaking of the Academy, you tell me about your vision for being Academy president. I'm so excited about that.
Well, I'm very excited too. So I'm president-elect, and I will transition to president January 1st. So it's a year position. And I think each president has sort of some passion projects. And I am giving a 5-minute talk at the opening session, and Dan Bryson will obviously have his talk as well. And I'm thinking about altruism, Uday. I know it's a tough time for ophthalmologists, well, for everybody, post-COVID, inter-COVID, post-COVID. Tough for ophthalmologists given the reductions in payments, staffing shortages, and it's not an easy time to be grateful or to be altruistic. But that's what I would like to address, is how honored we are to be ophthalmologists. I see the resident applications for our residency, and what amazing people are coming into our field, and how blessed we are really to have been given this opportunity to be physicians, the most honored profession in any country, anywhere. And in spite of these hardships that we're suffering on the business side, to think about, like, the reason Mitchell and Shannon gave their gift. Those who have been given the most should give back. So I think giving back for us, and one of the passion projects for me as president, is thinking about how we can give back. So caring for the safety net population. As I indicated, pediatric ophthalmologist, 50% of our patients typically are underinsured. Hospital district contract, CHIP, Medicaid, etc. That you can't run a business on that patient population exclusively, caring for that patient population, but see a few Medicaid patients, see a few CHIP patients, giving back that way. Another way to give back would be to take hospital call. So we operate in ASCs. Who wants hospital privileges, right? But hospital ERs are in a terrible situation with ophthalmology, ophthalmologists not wanting to take call. It is we did plenty of call as residents and fellows, and who wants to do that? But it is definitely a way to give back. It doesn't have to be a weekly thing or a monthly thing. Lots of the safety net population who do not have ophthalmologists, that's where they come through. So that would be another way to return the favor, to be altruistic and give back. Also, advocacy, right, through the academy at the state level, advocating for expanded Medicaid payments, like fair Medicaid payments that are equal to Medicare payments. In so many states, it's super variable, and it's really, really punishing pediatric ophthalmology. So I think it's Pennsylvania that a new patient, Medicaid new patient payment is like $58. Who will take care of these patients when no one can keep their doors open with $58 on a new patient? So parity to Medicare payments, and Medicaid is on a state level. So that's 50 states we have to deal with. It can't be done at the Academy DC level because Medicare is federal, but Medicaid is so much done on a state level, and that's why there's so much variability. So I'm sorry I went down a rabbit hole, but
no, these are important topics. These are very, very important topics.
Yeah, and so taking care, advocacy for scope battles at the state level, get involved at the state level in advocacy would be another way of giving back. So those are a few, and then the workforce shortage, current and impending workforce shortage in pediatric ophthalmology, neuro-ophthalmology, two of my fields, and uveitis, something to address. Although the subspecialty societies, NANOS and APOS, are working hard and collaborating with the Academy to address how we can incent residents to pursue those fields.
Wow, that's an amazing objective for your presidency. I'm really impressed. But boy, you've got a lot on your plate. Running your institute, director of the institute, chair of your department. You're obviously still taking care of patients, growing your whole department, plus being president of the academy. You are going to be one busy bee in the next year.
Yeah, correct. But it's great work. So when you're inspired and energized by your work, and you work in a institution where your values fit the institution. Uday, before I became chair here, I just figured that it was normal to agree with 50% of to not be fully aligned with the institution that employs you. Maybe 50% of the leaders you agreed with the decisions made at the leadership level. That was normal. That is not normal. It's not the ideal. That's a recipe for burnout. But if you're working in an institution or with people that you have a good cultural fit, your vision is aligned, you're in a value-driven organization, the work is not work.
Yeah, it becomes a passion project.
Right.
And then obviously the results will be even better. So where do you envision, if you had a dream, where would you have this institute in 10 years and then beyond? What do you think? What do you think is a reasonable thing to accomplish in, let's say, a 10-year period?
Add fellowship.
Add fellowship. Because you're laying down the foundation of a department that's going to last hundreds of years, if not beyond.
Right.
So your goal, what you're going to do now, your work is going to transform thousands of doctors and millions of lives.
Thank you.
So you said, okay, I'm sorry for interrupting. You said you're going to do add fellowships.
Add fellowships. Our first fellowship that we're going to have the TOC fellow will attend a clinic here at UT Health Austin. Also, the Austin Retina Associates now have a new fellowship that we've co-branded with Dell Med. That fellow will come over, but we'd like to add an anterior segment fellowship. I think we need to add a pediatric ophthalmology fellowship. My 5 faculty in pediatric ophthalmology are amazing, fabulous training, and committed to education and patient care, etc. And so, Uday, when I had to think about the department, there's the three-legged a stool of academic medicine, and that is clinical care, education, and research. And I had to, when creating the department and hiring faculty, I had to focus on not all three legs of the stool. I couldn't hire one of everything. And research is the next area I'd like to concentrate on. But the first area was developing the residency. Obviously, there was a time-limited ability to obtain the CMS funding for the residency. And that led to me hiring faculty who were committed educators of residents, committed to patient care, excellence in patient care. So the next chapter, 10 years, maybe our own building, adding another resident, adding more fellowships, and concentrating, having the ability to then concentrate on the research component. But you can't do research if you don't have a patient population either. So we're building that now.
Well, I love your passion. I love your enthusiasm. I can hear it in your voice, see it in your eyes. I have no doubt you're going to have an amazing department, an amazing Eye Institute. And I just look forward to just kind of watching it grow and blossom. It's amazing.
Well, thank you, Uday. It's been a real honor to talk with you, and you're equally as inspiring, in my opinion, and have trained so many residents selflessly, and these education of them on the business side and your cataract videos. Thank you for all you do.
Oh, thank you. I appreciate it. And for our viewers and listeners, remember, there's a new podcast every single week.
Wow.
Tell your friends about it. Yeah, exactly. Please like this and subscribe, and we will see you next week. Thank you for enjoying that podcast with me. I trust that you learned a lot. I really love that enthusiasm and excitement that Dr. Edmond has, and I can't wait to see what develops at that new department and new institution. Remember, we've got a new Cataract Coach podcast every single week, available here on CataractCoach.com, on YouTube, Apple, Spotify, Amazon, Google, wherever you get your podcasts. Please like and subscribe and tell your friends about it. And if you could do one last favor, please leave me a comment and let me know how you're enjoying the podcast and give me some advice for future guests so we can feature them here on this podcast. We'll catch you next time.